So in the time it's taken me to get on this stage, an emergency's happened somewhere at a hospital in Oregon. It could be in Eugene, where a 4-year-old cancer patient has presented in cardiac arrest from line sepsis. It could be in Coos Bay, where a 70-year-old has presented with stroke symptoms. Every day, these type of emergencies happen all around our state. Yet, these are where the specialists are located for pediatrics and stroke in this example. These occurrences are infrequent in some of these smaller hospitals and obviously very, very stressful. Before the advent of telemedicine, all the referring doctor could do was pick up a telephone and communicate to the specialist about what the issue was. My name is Miles Ellenby, and in the next 4 minutes, I'm going to explain to you how telemedicine has changed how we deliver this type of care. Because in the previous system, I was the one on the end of those receiving phone calls in the pediatric ICU. So, we're going to discuss how telemedicine transforms healthcare delivery by adding live video to the circumstance, where we are in the state of Oregon, and where we need to be going. The addition of simple video to a consultation, putting Skype on steroids, greatly changes how we partner with local doctors in helping making these decisions. The first decision we assist with is whether or not the child needs to be transported. And this is a huge, huge impactful decision. We do know that with our program, we've been able to decrease the number of transports. A fourth of the pediatric patients and up to 50% of the stroke patients have been able to be cared for locally. And the cost of medical transports are staggering. These are some of the numbers to give you an idea. Our program over the past 3.5 years has been able to save up to and including $3 million in unnecessary and risky transports. But it's not just about cost saving. Thank you. It's much more importantly about saving lives. So I'm going to give you 3 quick stories. That 4-year-old in Eugene who presented in septic shock, my partner joined the code team in assisting them. At one point, he asked them to give a fluid bolus, which is a rapid push of IV fluids. A couple minutes later, he sees in the room that's just dripping slowly in the background. He quickly redirected the team and told them what he really wanted them to do. Fortunately, aided by that, the child survived that and is now living a normal, healthy life. A crash C-section happened at 5:30 in the morning in Silverton. The baby was born, blue, needing active CPR. Our neonatologist joined their code team, quickly saw that one provider was trying to do 2 jobs, both open the baby's airway and breathe for the child. She redirected the team, encouraged them to split that into 2 jobs. And 12 minutes later in the video, the baby's crying, successfully resuscitated. The 70-year-old in Coos Bay, instead of his care being delayed by a long, expensive medical transport, our stroke neurologist joined their team, did a full exam, was able to review the CT, and immediately recommended that patient receive TPA, the clot-breaking drug, which in this case saved that gentleman from a devastating stroke that would have affected the rest of his life. Time is brain in these situations, and now we can eliminate the time barrier to care by adding video. So these situations happen a lot, and when they do, we do know there's some things that help. A phone call is great. Picture's worth 1,000 words, but live streaming video, it really is priceless. It allows us to see what's going on in the room. Some people call it telepresence. Now, I'm not comparing telemedicine to in-person care, which is obviously the gold standard. I'm comparing it to care over the phone alone, which has obvious limitations. So OHSU, Providence, Legacy all have active telemedicine programs going on. But at this point in time, we only reach about half the hospitals in the state of Oregon. Why? What are the limitations? Clearly the technology is there. The biggest problem is that we're providing 21st century medicine with 20th century regulations. Regulations that mandate credentialing at every facility create a bureaucratic nightmare. Inadequate reimbursement. Equipment that is expensive, but a lot less expensive than expensive medical transports. Lastly, it's about adoption. There was a big concern early on that the consulting physician would appear as big brother, looking over the rural doc's shoulders. But the truth has been the opposite. Our providers have been very happy, as well as the patients, with receiving care in this way. We all know how ubiquitous video has become in our lives. If you can Skype with your grandkids, why can't you connect with your doctor when you need them at the right time? This is what we really call healthcare reform, changing how we deliver healthcare so that you can get the right care at the right time in the right place. Thank you all.